Dr. Smijo Sebastian, great to have you here. Please tell us about your research.
So thank you, Shweta, for this wonderful opportunity, and hello to all my budding researchers, my dear children. My research is on the topic impact of social work intervention in the self-esteem, mental health, and quality of life among people living with HIV/AIDS. It's a long statement, but to put it into simple words, we are just looking onto the results of all those activities that we have done for the HIV positives, people living with HIV, and to know what change it has brought to their lives. So why this topic? That is the first thing I would like to share. COVID is in the hot seat for a long time, since its inception in the last December. Now it's almost a year. So we have very conveniently forgot about a condition called HIV or AIDS, which is with us for the many years since the early 1980s. And we all know that we are happy, right? In this particular point of time, we are happy that we are in the verge of finding out a effective vaccine for COVID. But just imagine the situation of a pandemic which is there for a long time, and we don't have any cure or any vaccine procedures for the people. So this is one thing that has led me to this particular issue. Secondly, when we speak about, I am comparing everything with COVID so that you can relate the similarities. Second thing is that when we speak about COVID, we know that it is more prevalent among the people who are in an age less than, or what we call the risk group is less than 10 and above 60. So when it comes to HIV, we know that it is with the people who are most affected are between the age of 25 and 45. So when we say 25 to 45, it's the productive age. They are the people who are the breadwinners of the family, and when these people become ill because of this particular situation, it becomes a public health issue. It's not just a health issue; it's become a public health issue with a lot of implications in the socio-economic condition of the people. So that's the second thing. And thirdly, being a social worker, it was always a curious part to know that we do a lot of things in a team, and what impact it has brought to the people. What is the change that has it brought to the people? So with these three things, I were the focus of my or which attracted me to this topic. So when I explain the term about the research title, to understand it, we have to know about the terminologies that I have mentioned. The first thing is the stigma. This is the word that is very much related to HIV, and now also we can see the same thing that's happening with this COVID infection. We are feared to deal with them. We keep them away. So when we say stigma, it's a prejudice or it's a labeling of a people, discriminating a set of people having AIDS, and stigma is there in various spheres. Second thing is the quality of life. So quality of life is a totality. It's not a single component, it's a totality. When we say about the physical, emotional, social, and spiritual well-being of an individual, when an individual is in its well state in all the spheres of his life. And the third aspect, the mental health. Mental health, as we know, it's a state of well-being. Again, it's a state of well-being. It's not merely being happy. It's when we say well-being when a person realizes his or her potentials and able to deal with the stress that he or she faces in the day-to-day life and able to contribute towards the community. So that is the mental health part. We have to be a productive part of the community. And self-esteem, which is the another important variable in this research, is the overall effective evaluation of one's worth, how we see ourselves, or what's the value that we give ourselves. Often these things are very much related into the context of HIV, since just being a person with HIV infection, community stigmatize, discriminates a person, and that affects the mental health, the self-esteem, the quality of life of an individual. So this is a brief introduction about my research. Now, I would like to say that what were the objectives that was set for this research. So first thing is that to know about what is the current state, like when I say about this particular topic, what is the current stage of their self-esteem, mental health, and quality of life, and to assess what was the change that happened after the intervention, and more importantly, results to contribute to the knowledge bank, and more importantly to the policy level. So developing new strategies and contributing towards the policy were the few aims of the research. Over to you, Shiv.
Thank you, Smijo. That was a great introduction and simplifying everything for the benefit of the audience. Considering that you wanted to study so much, I mean, you explained four concepts and you wanted to study them in your research, and you also wanted to connect how social work interventions, play a role. So, how did you go around doing this? What was your next step to actually explore all this that you were trying to study?
Doing a research in this particular topic, the first thing, like, we have to select an area where the prevalence rate of HIV is the highest. So Palakkad district of Kerala, which sees the maximum number of HIV population in the state, was selected for that particular reason. This is the state where this is the district in Kerala which has the highest number of PLHIV, people living with HIV. So what it was done is that we have to get it. It's not like we can ask in the public to know who are there is no database as such to identify the people who are in HIV infected. So generally what happens is there are organizations which support the people living with HIV. So first thing we have to do, we have to connect our research, we have to do the data collection and do the intervention in connection to a non-governmental organization. And I was lucky to be a part of Kuriakose Elias Service Society, which is abbreviated as KESS. And being there for the last 9 years, I am able to know these people for a long time. So first thing is that we had a database of 1,300 people who are registered with the organization, and there were 733 members who are willing to go with the research. So when we say that they are willing, their health should be health, the reachability, the willingness, all these aspects is to be an important part. Like, we cannot say that you all should participate, because it's not an issue that can be taken in like manner. The second thing is that we take consent from the organization and as well as with the clients. And the third process is that we have to set an inclusion criteria. So in my case, I took the people who are between the age group of 18 to 60 years, who are living with their family. The people who are isolated are not considered, because we want to know the totality of the issue. So the people who are with the family and the people who live in Palakkad. So the another thing is that there are people who have migrated from other part of the state and even the country, just to get rid of the stigma that they face in the particular locality. So these were the inclusion criteria, and an intervention plan was set to know how the change happens. So when I say intervention, it's a it's a very simple term. Like, we can say it's an activity, but an intervention is much more than that. It's a planned and a scientific activity where we help an individual, or it may be done with a group or with a community, to resolve their problems and attain a higher standards of living. So what the thing is that we need a change, a desirable change. And being a social worker, social work intervention, we follow the principles and methods of social work. So that is the intervention. It's a set of planned activities. So when we set that intervention, there were three major interventions, social work interventions, that was considered. The first thing is that it was the behavior change communication. Behavior change communication, as we know, these are the interactions that we do to bring a positive behavior. Or in other way, the purpose is to demotivate something that is not, that is positive for them. Say for example, alcoholism is not good for anyone. And when it comes to people living with HIV, it has more severe implications. Like, the people who are in medication for a longer time, when they are in the influence of alcohol, it not only gives any positive results, but it has a lot of negativity. So that is one thing. So behavior change communications was a set of interactions, or the communications channels, strategies, and methods that we do to bring some positive changes, positive behaviors. And second thing is the counseling. Counseling, we say it in a very common way. Whenever we give some advice to people, we all say that we do counseling. Here what we refer is about the professional, as a professional counseling. And why I say it's professional, it's done by people who have the technical know-how, who have the education qualification to do that. where a rapport is built. As we know that it's not easy to get the emotions or get the feelings of the people. So we have to build a rapport, and with that purpose, our intention is to support the people, to make them understand more. We don't provide solutions. What we do is we facilitate the process of understanding self, and they have the capacity, they develop the capacity to face their issues, and finally that contributes towards their mental health. And third aspect was linkages. When we say linkages, it's a process of making networks. We know that an individual entity or an organization or a people cannot provide a comprehensive support. So it's a collective effort. So when we say linkage, it's a process of services, resources. There are people, organizations who come together in a common platform to support the people living with it. So with these aspects, the intervention was planned and the group targeted the study group was selected.
Okay, thank you. So, what I understand is that you were looking at three kinds of intervention. So, one is behavior change communication that you explained, counseling, and the linkages and networking part. So, you were looking at how these three interventions play a role in changing things in life of people with HIV/AIDS. And you mentioned 733 people. So,
Yes.
so you had people, and you had already thought, okay, what kind of interventions I need to check in terms of their role. But what did you do as part of research? Like, how was this research? What did you do?
Large. So what I did is that we made a group of 150. It in a randomly. It's what we call as a lottery method, where every subject was had an equal opportunity to be selected. And with this 150, what we did was there was a pre-test and there was a post test. So it's an experiment. We are doing when we say an intervention study in the terms of research, it's an experimental study. So we have a group of 150 people, and since it's a human subjects, it was a it was an experiment method where we cannot. It's not like a laboratory settings, but of course we condition certain things to make to know the real impact of the change. So what we do is we talk to the people where how we are going with the business plan, and a certain module was prepared. Like it's not like giving one counseling, one behavior. So we provided around 20 behavior change communication, 10 sessions of counseling, 2 house visits, and at least 2 services were linked with these people. So this particular module of the duration, the intensity of interactions, and the nature of whether it's an individual basis, whether it's in a group basis, the whole house visits as a part of this. With all this process, a pre-state, like before the intervention, what was their status of their stigma, what was the status of their mental health, where their self-esteem, the quality of life was assessed. And it took around 6 months to complete this particular intervention. And later on, we by the end of the that particular scene, we collected the post results after the intervention. What was the change that happened? So this is the way how the research process happened.
Right. So, okay. So you selected within the larger group, you selected few based on the lottery method that you talked about. And then before you started your interventions, you asked them some questions to understand about their status. Then you did the intervention bit. And then afterwards, you asked those questions again to understand what was, if there was any change in the status of,
Yes, yes.
right. So in this process, considering that there were 150 is also not a small group. So when you were doing these interventions, when you were taking all this information, how were you remembering all that was happening? How were you remembering what is everybody saying and doing?
Yeah, that remembering the 150 itself is a big thing. But what we do is that we go with some with tools like what we say in our research. We use interview schedules, and we keep a note with us where we collect we have a very clear cut order where we follow. Like the schedule itself had a part where we collect the basic profile of the individual that is required for the research, and the other things like it's not like having a big question. It's like having some set of questions which give us which gives a single value. Like end of asking 20 to 30 or 40 to 50 questions, we get some single value which indicates that what is the particular state of mind. So this research is done like as I said earlier. We keep records of the process, and of course we take the help also. We use the assistance from the organization which has actually facilitated this research, and their assistance was also with, like, more importantly, like collecting the data we can do ourselves to a great extent, but to organize the people, like this 150 will be spread in around 90 panchayats of the district. So organizing the people, going to their houses, it always requires a sort of assistance by the people who are actually very close to them. So that assistance was there for me to conduct this research.
Right. And that's an important part, the fact that even as PhD scholars, of course, it's the job of PhD researcher to take things forward, but everybody needs help, and you have to know where the help will come from, who is going to play what role. So thank you for sharing that example. Now, once you had all this information from your interview schedules, you had all this data, how did you analyze it? Really, what happened next?
Okay, the data was coded in with the help of SPSS. So with this help of the software, I was able to analyze the data and come into some inferences that was important for the purpose of the objectives, to know that how, to what extent the objectives of the research has been met. So I used the software SPSS.
Right. Okay. So, and that helped you with the large data set that you had. Okay.
Yes, yes.
So let us understand more about your findings. Please share what were the key findings that emerged as part of your research.
Okay. So, as a researcher, it was very clear for me that when we do something genuinely for people, there will be something positive that happens. That was very clear. Even from before the beginning of research, I was clear that the results will be positive. But the curiosity or the challenge was to know to what extent, or what we say, whether that change was significant enough to say that intervention had a what we call a significance. The significance of that intervention was very important. So the first thing is that I always had a perception that when the education level is high, the stigma level will be low to a greater extent. But something which was not as to the level, like when we say, and my research says that the stigma in that particular district was very high, and that has a significant impact on the self-esteem, the mental health and quality of life of the people. So because of the stigma, what happens is that the identity of being a people of a person being having HIV was confined within the family members, and a less than 1% or around 1% had only disclosed the status to some other person. So the point is that there was high stigma in that area, and because of this reason, people have not disclosed their HIV status. And the second important finding is that despite of all the schemes and services, we have a lot of schemes that are available in general for people who are having chronic illness, and there are some specific services that is provided for people living with HIV. But because of the stigma and the so-called discrimination that will happen when you disclose your status, people were not ready to go and seek for the support, because most of the services, when we say government services or so whatever services, we have to outreach for that. We have to go and we have to disclose our status to someone. So what happens is that people prefer not to disclose and live in the sufferings, and people prefer to be in that particular state more than disclosing their status. So that was one thing. And the other important finding was that the understanding is that having proper medicines or having regular medicines will be the most influential factor in keeping the health of the individual. So that was the understanding. But to this, we can say that equal or even more to the having the medicines, what I found is that occupation is having a very important role. Occupation is very much related to the self-esteem, and having a regular income and family support is having more influence in the health of an individual than the regularity of treatment. So why I say occupation is having a very important aspect is that whenever a person is having an illness, what actually happens is it affects his livelihood, his or her income. So when the income is low, we cannot say anything that is, or we find ourselves in a very tricky position, that even though we would like to be positive in our thoughts, everything whatever happens to life will have its negativity. So that is one thing. And the final the main key finding is that I was able to substantiate my assumption or hypothesis that mental health, the self-esteem, the quality of life had a very significant change after the social work intervention. So these four things, I have more than 20 to 30 major findings, but these four things were the aspects which I like to share in this one.
Right. Thank you for sharing such key findings, and these are important ones. I'm also curious to know, like, did anything emerge that was surprising for you, like that surprised you? It was unexpected, and it came up in your research.
Okay. So when we say stigma, stigma has two direction. One is from the external source, how the environment and the people who surround us discriminates us. And second thing is that how we perceive it. So to my surprise, I was having an impression that it's the society who creates all the stigma. But what actually happens is that the stigma is has its internalized more than the external. The reason is that for a long time, people with HIV are considered as outcasted people who are immorally wrong. So what happens is that even though the social attitude has changed, the perception still remains that we are someone who are outcast. Second thing is that the one of the major indicator of the health of a person living with HIV, we check the blood count, where we say the CD4 count, specifically, which refers to the white blood cells counts of an individual, which is related to the immunity. So what I felt surprising is that more, as I mentioned earlier, it's not the medications, it's the occupation, it's the family support, it's the income, which has more contribution towards the immunity of an individual. So this is why reason why when we had this COVID, we always say that we have to keep a positive state of mind. So that these two were the most important, or what we can say, a bit of unexpected findings as a result.
Okay. And research is never easy. It always has a few challenges. So, what were the challenges that you faced as a researcher?
See, by hearing all this, it's very clear that it's not easy to intervene with people living with HIV. They are already so stigmatized, and discussing with the issue again and again further traumatize them. So, as a social worker, I have to be very careful while talking to them without offending them, humiliating them, and not they should not feel ashamed of it. So, that was a very difficult thing to discuss openly with them certain aspects. And second thing is that even when I say an experimental social researchers has a lot of limitation. We cannot set a very laboratory type very settings like setting the temperature to so and so value, humidity to so and so value. So people are influenced by their surroundings, and in my case, it's a community level research. So always there are some external factors that come into play, and of course, like any other researchers, time constraints and I have not used all the social work intervention. I have selected three interventions which I found to be more beneficial. So these three things can be referred as the challenges as a research.
Right. And I forgot to check with you earlier. Can you just tell us in which year did you do this data collection, and how long did it take for you to be in the field and do all this?
It took around 6 months. Like I started my data collection in the month of June of 2018, and by the next 6 months was for the intervention, and by the December I completed the intervention and started collecting the post test value. So it took 6 months for the process, but it took more than 2.5 years for me to set this particular intervention. I started my research in the year of 2014, and after the general procedures of collecting the review, collecting the introduction, and the setting this particular module and planning with this so and so group, it took us some significant amount of time. So
Mhm.
altogether it took 4 to 5 years for my research, and I was
Right.
awarded in the previous year.
Okay. Uh, and again, out of just curiosity, considering that you continue to work in the same field, like in the domain of HIV/AIDS and also with marginalized youth, and you also compared in the beginning about being COVID positive and what happens to people with HIV/AIDS. What has been the situation for people living with HIV/AIDS in the COVID context? Especially with the people that you've been working with.
Okay. The first thing is that the availability of medicines was a very serious issue. Like the one thing is that, as we know, the supplies have been stopped for a long time, and that is very much connected with the medicines also. So that was one thing. And when we speak about people who don't have any access to the private transportation, these people even find it difficult to pay their bus fares to reach the hospital. And you might be knowing that this ART, that the treat medicines that is available for HIV, is not available in all hospitals. It is only available in a single center in the district, and people have to travel more than 50 to 60 kilometers to reach this particular place. So getting the treatment was a challenge for them. And the second thing is that livelihood, just like any other community, when anything happens, like whenever there is a shutdown, whenever there is a lockdown, the income of people who actually are depend on the daily income, it affects a lot. So they are not salaried people. So these two things were the main serious issue. And what happens is that service providers like us are not able to function in our full fledged. We also face this mobility issue to reach out to these people. So these things were very difficult to them, but to some extent we were able to deal with it. And right now things are in place. We are able to somehow meet the so-called challenges.
I want to say to the viewers, people who would watch this video, what is it that you would like to recommend to them on the basis of your learnings?
Okay. I would like to just three things for you to take away from this interaction. The first thing is that awareness is should be a continuous process. Like we cannot sit in a place and say that we have provided enough awareness. This should be evolved, and there are certain aspects that has to be incorporated from time to time, and that makes the awareness a complete one. So with regard to HIV, we have to know that there are new areas that is emerging in our nation. The first thing is that we speak a lot about the homosexuality, transgenders issue, and these things have a very high implication in HIV. And the second thing is that the sex education, the need of sex education is a part of this awareness program. And also we should know that the incidence of HIV among drug abusers, the injecting drug abusers, are also one of the serious threat that we face. So awareness should be there and should continue. Even though we don't speak about HIV, we have to know that lakhs of people die every year because of this particular situation. Number two, it's not only a single point or single discipline that has to intervene with the people living with HIV. It should be a collective effort, and we need a multidisciplinary team. So what I am bringing is that it should be an integration. HIV cannot go as a single channel. It's not that cost effective, and it's not that what we call, it's not the principle that should happen in the development. So we have to integrate HIV intervention as a part of all our development activities. And the third thing, and the most important thing where this Ginny's planet stands for, is inclusiveness. So whenever we plan something for a group who are to some extent who are discriminated or who feel themselves as different, we have to put them into the center of our planning, and our interventions should be given. Our intervention should be designed in such a manner that their preferences are considered more than our conveniences. So these three things I would like to share as the takeaway of this particular research, and this can be further escalated for the policymakers.
Right, and it's very interesting to see how there are like synergies between what comes up as recommendation from you and what Guinea's Planet also focuses on, and recognizing that there is diversity in this world and it has to be respected. And many things make us similar, many things make us different, and that is all right. That is part of this world in our life. Uh, so thank you so much, Dr. Smijo Sebastian, for sharing so much about your research. And thank you, audience, for being with us in this conversation. Research for Everyone will come up with another conversation like this where we bring in another scholar who will talk about his or her research in a simplified manner so that it reaches everyone. Do follow our updates on our website, guineasplanet.com, to see what else do we do. And thank you, everyone. See you soon again.